The Pallium project has evolved into one of Canada's most robust examples of a community of practice. COPs are collaborations of people who share specific interests and practices and work together to advance their specific area of practice. A COP reflects a long tradition of working together in Canada among neighbors and within communities to share resources, energies, and efforts in mutual interdependence of common goals. It reflects a great paradox of our times. The simple idea of diligently working together to reframe the complicated question of how can we afford to provide services to an aging population into one which enables us to navigate the complexity of ensuring that systems of care are available when patients and families need them. In this report back to stakeholders, several collaborators in project activities share insights about the project's work, results to date, and the difference it is making.
You don't just plant seeds in a medium and expect it to grow. You have to fertilize it. You have to nurture it. And without Health Canada, I do not think that we would have had a chance to develop the kinds of ideas into implementable projects.
What I've witnessed and appreciated about Pallium is the fact that it came and it was something that was new and everybody was wondering, what is this project and what is it going to do? And what I have been privileged to witness is the fact that, yes, it came with an injection of money to do things that we needed to have done, but it also, along with that money, it came with the expertise and leadership of how to make the maximum or optimal use of that money.
It's almost like the time was ripe. There was certain individuals that were making a difference in their own organizations. There was a push from a variety of places. Money always helps.
I think it's had a wider scope than I thought that it would at the start, which is really exciting. Certainly it's a project that's thought outside the box from the start.
For us to undertake something like this ourselves, it would never happen. We just don't have it. We don't have the expertise, we don't have the time, we don't have the resources. So we need these projects to move it and to move it forward, and it is.
Rurally, we were really struggling and continue to struggle because of distance, lack of formally educated staff, lack of developed teams, and even our social workers don't have a lot of palliative knowledge / bereavement knowledge.
I think that we're trying to push primary health care reform across the country. We're trying to talk about education of professionals. We try to talk about the interdisciplinary model. Pallium has used our model of norms practice really well within what they do.
When we started, the idea of interprofessional education was still an idea. It wasn't really a process yet. Whereas now I think there is a process in that. It is surprising at how quickly things have moved forward. And I really do think that Pallium was helpful in getting that going.
I think Pallium's made a huge contribution to advancing hospice palliative care in this country. One of the issues that we've had is one of attention. That we've done a good job of starting to talk about hospice palliative care in various settings. We've pushed the envelope, so to speak, outside of those just working in hospice palliative care.
They've been a wonderful resource to rural areas for sure, and wonderful for the networking coordinators as well, because it certainly has given us tools to go out into our rural areas.
I think one of the biggest differences Pallium has made is to provide a mechanism by which the knowledge and expertise that is often quite tightly held in the big centers can be spread to the rural areas or the peripheral areas in the province where people are still dying, people still have the right to expertise in end-of-life care, but there have been challenges and barriers to get that expertise.
Pallium has taken off very quickly. And you know why? I think it's because it is not a concept that grew out of one person's head. I think it's a concept that might have started in Dr. Prieura's head, in Michael Ahern's head, in several others. But once it was shared, and once it was facilitated by resources made available by the federal government, and a lot of hands made the work light indeed, it no longer belonged to a small group of people. Pallium now belongs to everybody, and I think that is the reason for why its ascendancy and its diffusion, its acceptance has been just spectacular.
I think it's significant that Pallium, the second phase of Pallium, moved beyond education, moved into service sector development, moved into system change. This is huge and so needed because we work in a system that is a medical model of care. It is the system, the resources, the education, everything around it delivers the medical model of care, which is about cure. And hospice palliative care is about healing. It's a fundamentally very different model of care, requires different resources and a different service delivery mechanisms.
We want to make sure our cancer patients and families will receive the right care at the right time by the right people.
The one thing I think that is very important to our patients is continuity of care. And it's a huge component of care right now that I think is missing.
I think that Pallium did allow us to actually, at quite a high level, send out an invitation to CEOs and ask for representatives to come together in Vancouver and have a meeting and probably for the first time say, where should we be going in this province? And that was important to do.
For somebody who works in national health policy, it was thrilling to get those people in the same room.
In all of my other hats, I don't think I could have called that meeting because I really didn't have the jurisdiction to call it, you might say, in the positions that I was in. But I think through Pallium, that was seen as a national, that had national funding to improve capacity in palliative care, that it allowed us to come together and say to all the health authorities, how could we do this and what are the gaps in our province?
It was significant that Pallium went in that direction to try to provide leadership and tools and strategies to help those of us who are on the ground, either working at our local regional health authority level or working with our provincial governments, to help to inform them and to help to educate them and work with them to make the system changes that need to be made.
They are at different spots, but I think one of the values of having them come together is that they can compare and exchange stories and strategies and frameworks and mentoring.
One of the things that I've really witnessed happen through the Pallium project is how it's made our country feel so much smaller in the world of palliative care. One of the biggest challenges in providing palliative care in the rural regions is the lack of 24-hour coverage. And one of the ways that I see this as being possible is to enhance the 24-hour coverage in the rural regions is the telehealth nursing project.
That we were able through Pallium to leverage some ideas, dreams that we both, the Alberta Cancer Board and BC Cancer Agency, had and move them forward. The telenursing protocols project, that was something that initially was a dream of this ABC, we call it the ABC, Alberta, British Columbia, and Pallium give us the opportunity to leverage this original idea that, you know, kind of, that was shared with other nursing leaders.
A group in Vancouver, we discovered, had started a small pilot project doing exactly this. And they had some early outcomes that were remarkable. So we built on what existed rather than reinventing.
The surprise maybe was how much agreement there really was about what was needed, and always what you find, I think, when you start talking to people is that your problems are probably more similar than you think. And in some ways the solutions are too.
To be able in the middle of the night, if somebody is dying at home and it's 43 below and there's a blizzard, and you live 243 kilometers from your nearest tertiary center, you can call and have a nurse on the end of the line who will, very calm and with confidence, competence, compassion, and she will have a slate of palliative care specific information to guide you through.
And it will practically mean that, especially patients in rural areas where there is no after hours and night service, it's going to mean they've got a number to call, a place to get reassurance. It doesn't mean that we can always handle everything over the phone. But our experience in Fraser Health is that about 50% of the calls can be handled just by a telephone call.
We believe in it, we know there's a need, and we know that most people in our country have phones. Now it's to talk to the health lines about how are they going to take these protocols and build it into their system, and it is doable.
When we can go with a product to ministries of health and call centers and say, hey, we have a workbook, we have a tool, we've done this work somewhere else, you know, let's explore taking it up. Number one, that really gives them a challenge to take it up.
And I am grateful to this initiative that we've had the opportunity to even think about this kind of cutting-edge, frontline, easy access medicine.
I think there is potential for it to be Canada-wide. The principles and the developmental work that we've done could be adopted anywhere. And I've kind of used the analogy of a car. You know, we built the prototype of a car, but obviously the model and the paint color and whether you need a block heater or not is going to depend on where you buy the car and where you're gonna run the car. So we know that other provinces and other jurisdictions might need to do it somewhat differently, and that's okay.
If Pallium would have not been there, the telenursing protocols, which is so crucial for 24/7 access to for patients, would have never been implemented.
I think it will also ask other jurisdictions and regions to say, what services are you providing for patients overnight? And it will force them to answer that question. And if the answer is no, I hope they'll do something about it.
We know that we have some crises around Aboriginal needs, and you know, diabetes is their terminal illness, and you know, that's not right.
I think the potential is there to highlight that as Aboriginal persons we have something to offer to the total vision in the society around palliative care. I think we have been recipients of clinical models of care and of Western medicine. And in this particular project, I think we will now move to another level of participation and make some contribution to the Pallium project.
There have been people that have identified new learnings. We had one woman stand up in one of the communities in northern Manitoba and say, I've worked with Aboriginal people my whole life, and this is the first I've heard of the impacts of colonization in residential school. There was, I think, profound shifts for people.
I think the whole
concept about the schooling and history. I think we have preconceived ideas about what it was like, but to have it actually explained through the eyes of somebody who's been there and done that, and then who has moved through our system, the more Western system, has been very insightful for many people.
We have a huge Aboriginal population up north, and it was a shock. More than a surprise, it was a shock at the number of people that attended for the day that were really naive and truly did not understand.
They had never thought of residential care having an impact on a healthcare system and the care that was expected and the trust or mistrust that they put in white caregivers. And we're really hoping that it really brings us together, because there has been divisions, just cultural divisions, lack of understanding, and there's been several attempts to bridge those gaps.
I think what it did that day was really develop the respect for some of the challenges that our Aboriginal population have faced in the past, and how those challenges are still influencing, extremely influencing their lives today.
We burst some myths for some people, so they have to re-examine some of their philosophies and some of their beliefs around Aboriginal needs. And I think that people are now saying to us as a region, what are you going to do? You know, we need this support, we need this help. What sort of programs are available to us?
This workshop has really spurred on the cultural learning curve in our region, both in terms of culture for the Aboriginals and also for palliative care.
This was a bit of a first taste for people, and that it just made them aware of how much they don't know in terms of working with the Aboriginals. So that's huge. I mean, if we can do that, the rest will be easy.
It began with, I suppose, a personal passion and some shared vision in my own program in palliative care with some of the colleagues who felt that this was something that we could do, that there would be potential for the development of a competency-based education and spiritual care for hospice palliative care. It's never been done before, and we wanted to do it. So this was the opportunity to do it, and I would have to say there was a lovely synergy of people and time and opportunity.
We had the mechanism and the opportunity to do this. We needed dollars to support Dan to do it, but Dan had the wisdom, experience, and ability. And from this, very quickly launched a curriculum. People came to Regina and had this experience, a 12-week experience with us.
Just like healthcare professionals, all religious professionals do not necessarily have enough training or skills in their original training with death and dying and grieving, and how to, what are the spiritual issues related to that and opportunities for support. So there is a need for continuing education in that field, and so it was wonderful to be able to send our professional away to get that education.
It surpassed my expectation. It surpassed my expectation from where we actually got it to go to in the time we had. It surpassed my expectation with the people who came to us for training, just how alive they became, the joy that they left with, knowledge, ability, skill.
The degree of enthusiasm that the students have shown, the learners in the summer intensive training units, the learning laboratories that we undertook to test out this curriculum, I think their excitement in the whole process has been quite a rewarding experience, and there's a lot of interest in learning about hospice palliative care.
We immerse them in every piece of palliative medicine, looking at spiritual suffering throughout a continuum of care. So they saw people in the cancer center, at home, in acute care, in the hospice, and even people who were bereaved. And how did spiritual suffering affect every aspect of that continuum?
I think that whole program is significant to help to elevate spiritual care to the point that it needs to be in end-of-life care. I work for a community hospice. We're the psychosocial spiritual component of care. We know we're equally as important to the medical piece of care, and our medical colleagues acknowledge that. But often the medical piece takes priority. The resources, they take priority in resources and things like that. So this, I think, is significant in starting to reposition and position appropriately where spiritual care belongs.
They're just as important, if not more important, because in that last, let's pick a time, last 3 months of life, often there's an awful lot of work that the patient and family need to do, and spiritual or pastoral care are so important for that.
This is part of a national process which is slowly becoming more knit together as people become acquainted with one another, and it's leading probably to a more collaborative and interdisciplinary approach.
It was the rural areas that needed the most focus right off the bat. How are we going to engage these people? What are some of the unique ways to have education delivered to them or get them involved in education? Bringing them out from their place and plugging them into a large center isn't always the best thing to do, nor is it the easiest thing to do.
You want to build a specialized palliative care consultation team. If you want to build that, your number one, baseline training should be a rural weekend course.
Those weekends have been very successful, I think, in reconfirming a passion or compassion within people for palliative care. They've really sparked the interest and enthusiasm that's needed to continue that learning and affecting change of practice in their local communities.
People don't know each other, and they don't know who are the keys in the region sometimes. And I guess it's that isolation. I'm surprised at how bringing things together and having this regional weekend course just opens up so many more doors.
I know from people who've attended that it's made a change in how they've looked at palliative care.
Bringing all those disciplines together into a room, it's amazing how much people learned from each other and how much appreciation there was for different viewpoints. And people were tolerant of each other. And people challenged each other, but there was respect in the room.
The nurses maybe are seeing physicians that they thought were just grumpy physicians or whatever. They don't think they're interested in palliative care. And then when they start seeing them in the course and they start seeing the questions they're asking, they're like, wow, this person knows something. I'm going to call them up, and they're really interested. And where maybe the physician is just really busy in his multiple, patient practice, and palliative care might slip to the side.
Physicians at one time would be able to say, well, that's not, I don't need to worry about that. That's somebody else's problem. Or my job is to cure. My job is not to care about the patient. And yet, when something's happening in your own backyard and everybody else is buying on, it becomes very difficult for you to become ignorant or to pass it off as something different. And I think that Pallium has brought that focus up.
Who can deny that dignity-conserving work is bad? It just kind of levels the ground for us all, I think, and gives people a sense that this is kind of hallowed ground we're walking on here, that it's a bit of a philosophical shift, and that may not seem big to some people, but for some of our staff, that's been a huge thing.
They all are speaking the same language now, and that's an incredible gift that we've been given.
The caregivers that have attended those, whether they be the physicians, the nurses, the pharmacists, have recognized perhaps what they didn't know, or even more importantly, what their colleagues don't know. And they have gained knowledge that they can put into practice for themselves, but also share with others.
The nurses rurally function much better now on their own. We get way less phone calls than we used to get. The phone calls we're getting now are certainly more complex.
I think that most people are very pleased to have that group of people together, to see the skills that everyone can bring in.
And the weekend course, through vignettes and through case studies, gave them the advantage of going in and saying, you know, if you look at bereavement issues, for example, here's what we can do to help you. Here's what we know. Here's what we can proceed with. And they were more comfortable with their own responses because they'd been through the weekend course.
The one outcome that we really never thought about until we did reflection following the event was the team building that occurred during the weekend.
We're teaching them the value of the work and we're also teaching them the value of teamwork.
So I think I've heard a lot of that type of comment that, wow, you know, it's really nice to work with somebody who's been to the course and who has now the same knowledge that I do, and we can work on that together and see where we need to build the future for palliative care in their area.
Enthusiasm that people have after they've taken the course is remarkable. To me, that's one of the unintended outcomes.
Every region or health authority will get out of it what they want to get out of it, but the opportunities are great, because if you take a champion that comes to that course and thinks, you know, I can do this, I can spread this out and to the greater population of healthcare workers, then they will, and I think they'll do really well with it, because that's how the course is set up.
Rurally, we really, really need education. We need people who are willing to come to us, because we aren't offered a lot of dollars. So if you're expected to go out and enhance other people, you need to be able to access things like Pallium, and it's wonderful that they've come to us.
Pallium has helped to bridge down and gown. It has also helped to bridge the people who are in search of learning experiences and those who are able to facilitate those experiences.
I see that it's being kind of that spark, or the seeds that are being planted across the regions and are there now to germinate and grow.
Pallium has helped organize not just 2 or 3 persons' ideas, but ideas from many sectors, many professions, many regions, urban, rural, many disciplines. People in the community with people in the academic community.
I started off as a broker of other people's information and have become a repository of a rich sense of knowledge and wisdom. I believe it allowed the one elder advisor that has now passed on an opportunity to give a meaning to her life, that her ability through the end stages of her life to contribute to this initiative became a very important priority, and her leaving a personal legacy behind.
It really has been a fluid process, and I think the resource has been tested adequately to know that it is relevant, necessary in non-Aboriginal and Aboriginal community.
The LEAP is really nice. Again, interprofessional can be used in a number of different ways, and that's an excellent legacy piece. I don't think anyone was well organized enough and far enough along to put this together and say, look what we've got.
The LEAP courseware as it stands now is an incredible piece of work that totally illustrates the complete care of body, mind, and soul of a person in the palliative care phase.
The LEAP courseware has made a difference in that it's really brought credibility to palliative care in general, and also has given credibility to the people who have facilitated the courses.
The handbook, I have resourced to absolutely every facility. I mean, they use it all the time. You'll go into a little community and it's all stickered off, and they'll have it right out with their physician saying, yes, but this is what, you know, the Pallium workbook tells us to use, and they'll try it.
It is an incredible package now, the way it is set up. And it shows the hard work of individuals sorting out what needs to be in. I think it's a tribute to many people who have been involved since the beginning.
They actually showed the final bit of LEAP at the last FPEC symposium, and every school brought home one because it was really a good thing. It was an excellent tool to use for education.
It's an incredibly concise, well-documented version of what we initially talked about 5 years ago.
It's the tool that we've been waiting for in palliative care to take teaching forward. If I could look at one project that made a huge difference, probably the spiritual care initiative was one of the greatest, because the outcome is demonstrated, and there's a complete curriculum now that we can share.
We're translating that education as much as we can through workshops, as well as it has certainly impacted the training of our volunteers and any of the professional training that we're doing.
At this point of its lifespan, there's a lot of drive towards the sustaining momentum of what it's done. So that's insightful and generous, because it does involve sharing resources that Pallium has developed through their project, and sharing them, and sometimes even in some ways relinquishing profile and control to other groups or bodies of palliative care service deliveries.
Pallium has been successful in creating some wonderful core curricula that are extremely useful now, and they will continue to be useful in the future. But one of the things that they're going to require to continue to be useful is an infrastructure and support that allows an ongoing evaluation, so they continue to stay current.
It is the people who work with these initiatives, who are at ground zero, so to speak, who will perhaps tell you, if they haven't yet, how it has touched them, how it has enhanced their opportunities for career development, how it has stimulated their minds, sharpened their competencies, enabled them to provide better service.
With the resources that Pallium brought, it started to bring people together more frequently and often to discuss issues around education and innovation in palliative care that we never had the opportunity to do nearly as frequently before.
We've gotten to know people across all Western Canada. It's been a huge link. I think it's probably helped to join the palliative care world, and for us to realize what a small world that really is, but how similar we all are.
Pallium is a key leadership piece and a key support piece to helping us do the work that we need to do, and I can tell you we are desperate for it.
I'm also excited because I learn out of all this. You know, medicine doesn't prepare you for anything other than clinical care of a patient. That's the formal way medicine has been structured in the past. But when you get out into the real world, there's a heck of a lot more to it than that. And I think Pallium was really important in kind of opening my eyes to that.
So I've spent 22 years as a maternity nurse, and I can tell you that we were never given this advantage in a maternity rural setting. So to move into a palliative setting and be given these tools and these opportunities is amazing.
while we got involved in that because we're just passionate and believe so strongly in it and want to make it happen, has just had tremendous benefits to the organization that I work for in terms of its profile and recognition and leadership responsibilities. So that's been a wonderful outcome.
I think it was quite visionary because I didn't, to be honest, before Michael and Jose kind of got this going, I didn't really appreciate that, A, the degree of the gap, and B, the mechanisms by which that could be addressed.
For a number of us who are in leadership roles in palliative care in BC, I think it's probably caused us to look at how we are organized and how we can move ahead perhaps more synergistically for change.
The project has challenged us to think about how can we be more effective in doing the work we're doing, and how can we more effectively help to change the practice of those around us. So rather than being frustrated and feel that we're not making a difference, I think it's challenged us to think about how we can do that more effectively.
It's generated quite a bit of discussion in my own profession to begin with, and quite a bit of interest in some of the others.
All of the facilitators that I've worked with have also told the group that they're with is we all learn. Every weekend that we teach, we learn. And so that I think it reinforces that it's a never-ending learning piece.
They've been a wonderful resource to rural areas for sure, and wonderful for the networking coordinators as well, because it certainly has given us tools to go out into our rural areas.
We feel more confident in our ability to teach about palliative care.
There was just an amazing kind of coming together of energies where this project showed up at a time where people needed to hear the information. We had just so many different grieving processes and loss processes that were being supported in community while learning at the same time.
Just bringing people and leaders in the field together to create that kind of synergy and energy and commitment to working together is just significant.
There's a lot of good energy here when you talk to people, and there's a lot of things that other people are doing, and you're wanting to kind of work with them. You don't want to work in silos.
It takes perhaps one or two key people within a region feeling like they're alone in promoting this palliative care effort to a much more wider group of people that are out there.
We can learn so much more from each other. We can borrow from each other, we can share with each other, we can learn from each other, we can support one another.
Pallium has done great things for us. I think it's probably one of the best things that has happened to palliative care ever.
I remember that was one of the key things when we started Pallium, the first iteration. It was, we need to build capacity. Well, guess what? The capacity is being built. I mean, it's there. You see it. You see it across the country. And you see the support that Pallium has lent to various projects across the country.
Big picture, Pallium has really opened a lot of eyes across Canada, especially Western Canada, where this basically started out, but now has expanded to Eastern Canada and to the Maritime provinces, and that's incredible. And we're still getting people calling. I'm getting people calling from Ontario saying, when's it coming to us? So I think it's just snowballed.
I think that there are probably more unintended consequences of this initiative, but the one that surprised me, and pleasantly so, is the rapidity with which the idea of Pallium has been embraced by many different sectors.
I believe it's part of a national process that's taking place, a ferment that's building in a number of the disciplines, to have a more coherent, accountable program of education and qualification for this kind of work, so that we can bring good quality of care to the bedside.
One of the legacies is the experience of the people who've been involved. And that experience will continue in the areas that people work in, the different cities and rural areas. They will then be the teachers and educators for the next generation of people who will do clinical work in education and research in palliative care.
People are saying to us, what next? Like, okay, that was level 1, we're looking for level 2.
I think 3 years gave us a start, a great head start. Now where can we go from here? And what are the next steps so that it just doesn't fall off the radar screen?
There's much work to be done, and we have just a wonderful start, that there's committed minds and hearts across the country beginning to work together on this.
We are remembering how to be palliative caregivers in Aboriginal community. I believe we are really remembering what we used to be able to do in our communities, and we may find enough health and strength to do it effectively again.
Pallium clearly has great potential to help us continue with innovative education, both locally in our large urban areas or rural areas, and in distance education, but it will only be able to do that if the resources continue to exist to allow us to do that.
And I think that Pallium needs to have a national legacy. Hoping it goes into another phase, but depending on what that phase looks like, I still think that there needs to be a national legacy for all the work that's been done.
It's important for people to know that Pallium came out of just a few ideas, but when you look at the legacy of the project thus far, I mean, even though we're not at the end yet, but we can certainly see tangible benefits all over the place.
You have to always remember that's what our work is about. It's about making change for patients and families. How do we do this work more? How do we do this work better?
I truly believe that the work at end of life in palliative care can begin a ripple effect that will move through the healthcare system, and it's a ripple effect of heart-based, spiritually founded care that is truly more compassionate, more responsive to diversity and to the needs of individuals and families. So I'm very hopeful that it's going to start something very big in the health system.
What is sustainable here, like many other great institutions, are the foundational ideas. Innovation, the idea of participation, the idea of collaboration, the meeting of the minds, the willingness to work in an inter and multidisciplinary context, the willing to suspend disbelief and keep the mind open and to explore. And this, I believe, are not unique to Pallium, but they are embraced by Pallium. And for as long as these foundational principles are alive, Pallium will evolve just like any other institution. And that is the legacy.